acute direct medical care costs is going to be much smaller per individual than the total societal lifetime costs. We also see a great difference in looking at the data that we use. So looking at medical data, acute admissions, fatalities, all injuries, when we add costs that maybe the victim and the shooter, so we get into what are the costs for the justice system, and then when we get into the population impact, what are the pain and suffering, what are the community costs, what are the disparity costs, we see that these costs also get very, very large. But no matter what estimate we are using, the cost for gun violence is jaw-dropping. It's staggering. It's a cost we should not be willing to take from either an economic standpoint and certainly not from a social and pain and suffering standpoint. The estimated median charge per patient for a firearm admission is $47,000. That's 4 times higher than the AHRQ tells us is the average overall admission for a hospital stay. And in the US, this is borne primarily by public sources. When we look at both uninsured and Medicare, Medicaid, it's over half of the costs. So these are important. They're necessary pieces of advocacy arguments. They're not sufficient to make the argument. We need so many additional data points. But I want to talk just for a second about how varied the data that we use is, because we all do need to be aware that there are a lot of data sources. They all have their strengths and weaknesses. If we look, for example, in the US at hospitalization rates from the 2 most common sources of data related to traumatic injuries, one is from HCUP, one is from the CDC Whiskers website, which is one of the best websites to play with data ever. We see they vary over time. I haven't updated this because the HCUP data requires a paid subscription, which I no longer have, but I just wanted to show you that there is variation over time, and that will have a huge impact on the cost estimates. We're not alone in the US in having this issue. So for example, these are data that show variance in estimates of homicide rates in the country of France. So France is a country that has a national health system. It has good census data. It has good death data. And even with that, counting the number of homicides per 100,000 people shows a range over the different sources of those estimates. When we look even more globally, in 1990, looking at this heat map, pay attention in this slide to the countries for which there is no data. So many countries, we are not able to count the number of homicides in an estimable way. The World Health Organization has many ways that they do estimate deaths by cause that include community autopsy interviews, that include estimates from hospital data and weighted estimates based on some of the known pockets of good death data. But what's really interesting is that when we look at 2021, there's some improvement. We do see that some countries have invested in health data infrastructures, but we still have very large swaths of the world for which we don't have accurate data. And many of these countries are countries that have political unrest. They do have wide availability of guns. They have very active gun markets, and often they don't have systems to register and track firearms that are owned either by military or by individuals. So I want to focus a little bit on, we usually feel pretty confident that we are good at estimating the number of deaths and their cause in the US. And I will say we're very good at it, but it doesn't mean we don't still have some work to do. If we look on the left side at the injury pyramid, which is the sort of slope of the relationship between the number of deaths to the number of hospitalizations to the number of people treated and released from care, we see that there's a fairly standard slope. And for the most part, hospitalizations and emergency department visits are far more common than injuries, than deaths. If we look at firearm injuries, we see a much different slope, and that we have as many hospitalizations as we do, or very close hospitalizations to deaths and treated and released, because it is such a lethal means. And this is data from 2017, where we have seen, as some of the speakers said earlier, seen an increase in the number of these. And so this is important. It's largely in part driven by the suicides that David was talking about, because they are so lethal. But when we look at assaults, there are many, many, many people who are shot who don't die from those injuries. So let's think about those for a moment. We have, in 2017, 70,000 people who were treated in a medical facility and recorded as being related to a firearm, what was their ultimate cause of death? And are we really able to track all of these back to what might be an initiating event that led to a cascade of events that ultimately caused perhaps a premature death? It might be that someone was shot and had a spinal injury and then died from medical complications from that spinal injury. It also might be that someone was shot multiple times and had many bullets left in their system. And I think all of the medical professionals, emergency department doctors and nurses, and acute care specialists can validate the fact that many people are walking around with bullets in them. Perhaps they're leaking lead, and that's going to lead to some health consequences that ultimately cause medical reasons for death. But there also might be reasons that maybe you're shot and that leads to you losing your job, and then you lose your health insurance, and then you lose your house. And so there's a social spiral that might lead to an early death because of complications related to those initial injuries. So even though we are pretty good at counting acute events, we're less good at counting what are the long-term events and costs personally, economically, psychologically, to individuals, families, and communities related to firearms. So I'm going to end with just, why does this matter? Why do we really care? One is, again, this is a strong value proposition to bring partners to the table. For example, industry interest in insurance costs. In tough economic times, especially looking at startup and new companies or emerging companies, costs for insurance are a very important business issue. It's a struggle for businesses. So if there's a lot of cost associated, there's going to get some attention, certainly congressional attention. But it's also very important, especially for all of us, to be advocates for how important data quality is. It's imperative to advance evidence-based practice and policy in understanding what are the priority investments for action, what are the impacts of those actions, and how do we maintain an evidence-based strategy, which is going to take multiple approaches to really drive down our injuries and the consequences from gun violence.
Thank you. And now we go to John Rich, Director of the Rush BMO Institute for Health Equity at Rush University.
Great, thank you so much. It's really powerful to be part of this discussion and to build on what we've talked about before and to think about the impact of the report. I want to talk a little bit about firearm violence, particularly the connections between trauma and health equity. And as you know, health equity was a cross-cutting key theme throughout our work to think about the impact of firearm violence on community. And I like to start with some aspiration. That is, what would we want to see that all of us could embrace? And so for me, our aspiration might be that all people will have the opportunity to be safe from intentional and unintentional injury due to firearms, as well as free from the physical and psychological trauma of violence, which we know has downstream consequences. Just as Corinne was talking about, how do we map the influence going forward? From a health equity perspective, and as we teach public health students, we know that this issue is sometimes depicted in Black and white, but an intersectional perspective helps us understand the ways in which different identities put individuals at risk for these consequences. And we know that young Black and brown people in cities are disproportionately impacted by firearm injury and death. But we know that middle-aged white men, often in suburban or rural settings, have higher or climbing rates of suicide. For children of all races and ethnicities, the prevalence of firearms has led to unprecedented levels of injury and death. And we know, for example, that transgender and gender nonconforming people are also at a particularly high risk. According to the HRC, nearly 2/3 of fatal violence towards transgender and gender nonconforming people involved a gun. And the majority of those victims were Black women under the age of 30. And so this is an issue that crosses identities, requires us to take an intersectional lens to understand these risks. And that speaks to the issues of complexity. And I think throughout our work, we have to embrace and understand that there are complex facets to this, many of which are most salient to those people who are directly affected. And so there are ways in which trauma feeds the cycle of violence. And certainly the manifestations of post-traumatic stress, which are at very high levels in inner city communities, drive this. So hyperarousal, flashbacks, nightmares feed this. In my own work, as I've interviewed young people who have been victims of violence, patients of mine, I recall talking to a young man named David. He and his cousin were sitting in a car in Roxbury, Massachusetts, actually. Someone walked up to the car, fired into the car. David was injured, had a non-life-threatening injury, but his cousin was killed. And I sat with him and he described one of the most disturbing manifestations of post-traumatic stress, that is emotional numbing. He said to me, some things that I used to be nervous about or scared about, I'm not scared of it anymore. I feel like I've already been through the worst. Like if someone kept on giving me mean looks, I used to get nervous, but it doesn't happen anymore. It just doesn't happen. It's like some of the feelings gone. I just look at them right back now, like what? It's like they took some of the emotions that I used to have, that nervous feeling, that scared feeling, it's gone. And so one can think about what is the impact of the loss of the ability to feel fear on a young person who's living often in a community that's economically disadvantaged. Well, we know that there's a cycle. And as we've looked at young people who have experienced a violent injury, data suggests that up to 44% of people who suffer a penetrating injury will suffer another penetrating injury in the subsequent 5 years. But there's a cycle. Injury can lead to symptoms of traumatic stress, but those symptoms themselves can lead to, and in the population that we talk to, behaviors that are about self-medicating, so the use of marijuana or cannabis to ease those problems. But of course, using cannabis subjects you to risks in the criminal justice system. It will bar you from employment. And when you're barred from those basic opportunities, you may find yourself forced, as it were, into illicit economies where weapons are common. There are other ways in which, for example, lack of faith in the police to protect you may lead young people to get a weapon because of their desire to, in their own words, protect themselves. Now, I offer this not as an excuse for these behaviors, but an explanation for what is happening among young people. And so even as we think about systems thinking and complexity, the kinds of skills that we want to encourage amongst our learners, we have to think about the ways in which, for example, bounded rationality means that people make quite reasonable decisions based on the information they have. So if young people turn to weapons, that may feel rational in their lives, but they don't have a view of the entire system. Our interventions that we might envision around firearms might have themselves unintended consequences. So, for example, as we begin to talk about or plan for regulation to decrease availability of firearms, we know that that may increase the tendency for people to purchase firearms in anticipation of some change in availability. And certainly we know that there are feedback loops, so that to the extent that people feel unsafe because of the presence of firearms, so they feel unsafe, they may purchase firearms. More firearms lead people to feel more unsafe, may drive people acquiring firearms. So we have to think, I believe, in complex ways, and we have to intervene in those ways. So As you may know, across the country, healthcare settings have become a point of intervention to identify those people who have experienced prior injury and people who are suffering the consequences of post-traumatic stress to intervene. The Health Alliance for Violence Intervention is an organization that has supported the development of programs across the country. They now exist in many cities. And they have brought together professionals from many different disciplines. And so I speak to here the need for a public health approach that thinks about interprofessional work and interprofessional teams. And so we see in many of these interventions, public health people working with nurses, social workers, community health workers, violence interrupters, physicians, psychologists, a whole range of different disciplines. And together, pushing for policy change, for example, changes in Medicaid policy at the local level that may allow for resources to flow to sustain these programs. It is this kind of coming together across the range of disciplines, and I would include law enforcement here, with the understanding that from a public health perspective, we want to identify those root causes. We want to move forward with a healing perspective, not a punishment perspective, and we want to change the environment together to decrease injury. This is a key component of our work going forward and the opportunity that we have to decrease firearm violence among those who are most vulnerable.
Terrific. Thank you so much for your presentations, panelists. I'd like to start with just a few questions. John, actually, since you just gave your presentation, I had a question. So I've written before about hospital-based violence intervention and how it can really be very, very effective at interrupting that cycle of violence. I understand it starts right at the bedside and continues after discharge, ideally. Can you tell us a little bit more about what that involves, the logistics of it, and how you can engage somebody like after discharge and continue with them through their life, as some programs do?
Yes, thank you. It's a critical clinical question in that we encounter people who have experienced violence or are suffering from trauma, often at the bedside, but not necessarily, that we may actually reach out to them afterwards. And the goal is to engage them in understanding whether they're safe, to orient them to the possible consequences that may occur after injury, like post-traumatic stress, and to deal with these other health-related social needs, which are a critical piece to evaluate, certainly because we know that ongoing involvement with the criminal justice system, ongoing substance use, whether for self-medication or not, will often derail these young people. The goal is to use a team approach, that is, people with social workers, psychologists, paired with community health workers that represent people with the lived experience, and to have a tailored approach that meets the needs of the individual. And so it is very much a clinical initiative, but it's paired with public health professionals and public health principles. And so increasingly, as in Philadelphia, the public health department is engaged in this work by supporting evaluation, supporting quality, supporting training, and using innovations like guaranteed basic income for participants in these programs, recognizing that a fundamental driver of involvement in illicit activities is lack of access to resources. And so we're looking to do a wraparound for those who need it. For some, and it's tailored, for some they may need only one or two things. And the goal is to connect them with existing systems where they exist, to walk with them for that 6 to 8 to 12 months, and then to use and to advocate for greater support for young people and victims or survivors of violence in those settings.
Thank you for that. Yeah, hospital-based violence intervention relies heavily on credible messengers, but that's also something you need when dealing with gun rights advocates as well. David, you mentioned that you've worked with gun trainers on suicide prevention. The National Shooting Sports Foundation has paired with the American Foundation for Suicide Prevention to reduce suicides. How receptive has the gun industry and gun rights activists been overall to this push for suicide prevention? How do you broach that community, which can be kind of closed off, especially in light of this political stalemate
Right.
we're in?
So who in my group has done really all the yeoman work is Kathy Barber. And I think being a woman actually helps with the gunners. And so the example in Utah about the gun trainer, she went there. Utah's this red state is the gun training capital really of the United States. And she got herself invited to this group of concealed carry trainers. There's all this huge group. And she basically said that she said, do you realize that, I think you're doing such a good job trying to reduce gun accidents, but did you know that in Utah, and this shows the importance of reasonable good data, that in Utah, for every accidental gun death, there were 85 gun suicides? And they said, that can't be true. We don't know that. And then she said, oh, raise your hand if you know someone who accidentally killed themselves with a gun, and a couple of hands go up. And she said, then raise your hand if you know someone who committed suicide with a gun, and every hand goes up because there are all these old white guys and and they have guns, and they're the ones who had really high risk for death. And then she said, what if we work together and creating a module? And they just loved the module. And then they said, we need to get, because it wasn't the government stepping in. It was much like Friends Don't Let Friends Drive Drunk. And it was, how can we get all the trainers to do this? And then they thought about it and they said, it's going to be hard to train them all, to train all the trainers to understand this. She says, what? We know so many people in the legislature, we'll just make it mandatory. And so now Utah, this red state, is one of the 3 states in the union where it's required for, if you teach a concealed carry class, to have a module about gun suicide. And I think it's, she's worked with, really in the public health community, has worked with gun shops. It really started in New Hampshire, this one gun shop. Then the gun shops aren't very big in New Hampshire. There's lots of them. And in 1 week, 3 people came in and bought a gun, and within 6 hours had killed themselves. And the gun shop owner, when he found this out, was devastated, and he thought, we have to be able to do something about that. And it's not like it's going to change everything, but it really means if there's a woman comes into your shop by herself and says, I want a gun, and you say, okay, what kind of gun would you like? And she says, I don't care, any gun's fine. And you say, okay, how about this one? She says, great. And then you say, well, how many bullets would you like? And she says, one's enough. And you don't need to sell the gun to this person. It's not going to affect your sales, but you can help that person at that time, maybe get the help she needs. And as in 20 states now, gun shops are trying to think about the kinds of things they can do to make a difference in this, because at the individual level, not at the level of these lobbying organizations who you're not going to change, but at the individual level, everybody, everyone agrees we're trying to figure out ways to reduce gun deaths. And as Linda said, trying to figure out ways to live with these guns rather than so many people dying or being seriously injured by these guns. To treat these people as allies, that they are not the problem, but they can provide the solution to the problem. That they help create, I think, the best PSA I have ever seen. So it's this 30-second PSA, and briefly, there's a guy who's clearly a gunner. He knows what he's doing. And he's shooting bang, 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 bang. And then he turns to the camera and he says, last year things were really going bad in my life. And my buddies, they took my gun for a while till things got better. And, I think they saved my life. And then he puts his earmuffs back and he goes, bang, 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 bang. And it's such a success story because it's not just things are bad, but here's a way that you can help reduce the problem. And here's the success in a real person really having And so, yes, there's ways, and it's not the only thing to do, but it's, as we understand, as Linda pointed out, in the motor vehicle area, it's not like we got rid of cars. It's not like, we fixed everything, but we made the cars safer, and we can make the guns safer, and we changed the way people behave so that we have designated drivers now more than we ever did in 50 years ago. And so there's lots of things, and that's really is sort of the public health approach. It's not the nanny where all these nannies looking at it. It's trying to work together and try to figure out ways to make the world safer.
Yeah, so definitely facilitating a cultural shift in the absence of legislation. Corinne, I understand you want to chime in on this.
Yeah, I do. There have been consistent findings in surveys of gun owners that the vast majority of gun owners are in favor of reasonable approaches to reduce gun violence. And one of the things we can do in public health is create a very engaging culture that we can reach out and involve them in things that they do agree with. Because I think, as David said, many approaches are going to be very directly related at gun design, gun ownership, gun carrying, gun regulations. But a lot of things are also going to be, and we're going to need things that aren't directly focused on the firearm itself. And John talked about some of those. We need social change as well. And so I see some questions on advocacy. I hope that comes up, but we need to build the largest advocacy base we can. So we have to play a little politics. Where do we find ways to move forward that we can agree on, and recognize and be okay with the fact that there are things we don't agree on? And the last thing I want to say is, in addition to suicide prevention, there are also many ways to access youth. And that is, we know from other injury prevention, we've seen a culture change in how we think about safety, how youth can be drivers for changes in safety culture. And I think, looking at high school track clubs, of which my daughter was one, of thinking about how youth, see and are literate about what they see about firearms in the games they play, and how does that relate to their fear in their own neighborhood. So I think that we can be more savvy in creating an inclusive culture to talk about these things.
Another cultural shift could possibly be triggered by the market, financial pressures. And Corinne, I'll direct this to you. Since taxpayers pick up so much of the tab for the country's gun violence costs, can you foresee a point where it gets to be more than the economy can bear, and lawmakers are forced to step in, or private insurers start to balk at these costs? At what point do the economics outweigh the political considerations, and can that finally be what moves the needle?
I'll be honest that I don't think that is going to be the thing that moves the needle. In our legislative process, there is a big disconnect between cost now versus cost later, and cost in my appropriated bucket versus others. And so it's good to bring cultural attention to it, but I do think we can use economics to bring more people to the table. I don't think, for example, there are many CEOs that have looked at how much a gun suicide, a gun shooting has cost them from an insurance standpoint. There's more and more recognition of this in cancer treatment and how much that can cost. So I think that it's a very important, maybe necessary but not sufficient piece of the advocacy argument at the appropriation level. But I think it's an even more essential and powerful piece to bring more people to the table who, even though we're getting so much, growth in public interest, can help people understand, this is your problem in a bigger way that you may not have known.
Right. And on that note, Linda, you mentioned how motor vehicle interventions were and tobacco control. There were big strides made that haven't been made on gun violence, but motor vehicle interventions were accompanied by legislation, and tobacco had the master settlement agreement, which, because of the gun dealer immunity, is not really possible here, except in a few states. Can gun safety education and advocacy ever be enough? I mean, I guess the hope is that the cultural shift will come from a number of places. But is that possible without legislation? And how far can that take us, the education and advocacy?
I think that, education and advocacy is important, but I think we also do need to have changes in the way we do things. We need some changes in technology. I've seen a couple of questions, and I think there's a few questions about whether there's ways of changing the technology of guns so they can't be fired. But we know there's ways of making a gun so that it can only be fired by the owner with a thumbprint, and people get worried about that, and then you think, well, what do we do with our phones, our cell phones? We put our thumb on it to open it up. I mean, we're not risking this identity theft in the way that a lot of people will talk about it. So there are some things that can be done. And so I think education and advocacy alone are not going to do it. Policy, I think we need to recall that a lot of the policy is at a state level or local level, not at the federal level. And I think people tend to forget that and tend to make some assumptions that almost all the policy is federal when it's not. There's so much of it that isn't, and there's so much you can do in your own state. So that's one piece of it. But the interventions have to be funded. The programs have to be funded. And I think that's as when Corey was mentioning, some of the economics of it. Yeah, the economics are, they're a challenge. You asked her whether we might argue about the economics and how that might really get people engaged in it. It's a challenge to get people to listen to the economic argument. There is some funding in, the legislation that was passed last year. There's some funding for some mental health interventions. There's funding for some violence prevention, but it's not something that's long-term funding. It's not something that we're going to be able to just keep on using, and it's not going to necessarily take care of all the problems. But we need more than education and advocacy. We need technology. We need, with motor vehicles and tobacco, social change, cultural change. We need to look at some of the issues of equity, the disparities that occur, as John mentioned, about non-binary gender identification, how that impacts something. We also need to look at the assumptions that we make about what happens. And even with the data, where when we use certain classifications in data, sometimes, we classify race, but we don't always classify it correctly. We classify it incorrectly, and assumptions are made based on that classification, that because you're a specific race, you're at more risk. That's not necessarily the case. There may be other factors involved. So we really need to look at the other public health issues of social determinants of health to understand more of it. So we have a lot to do.
I'd like to ask one last question before we get to the audience questions, and this could really be for any of our panelists. How will the new White House Office of Gun Violence Prevention affect your work? I know there was a demand for it among survivors and that community because it showed that the president prioritized the issue. But aside from that, will having this office where gun violence response is streamlined make your life easier at all, whether it's data collection or messaging or advocacy or funding? What are you expecting to come out of there? Anyone can chime in.
I can start. And unfortunately, it's so on one hand, we've seen a lot of offices that have no funding behind them started. It's really hard for them to make a difference. It does bring a level of attention. So I think it has yet to be seen, but it's going to be a struggle.
I think it's going to also depend on what the focus is as well. I mean, we hear a lot of people say, oh, we can take a public health approach, but all they do is give it voice. They don't really understand what it means. And so it's going to really depend on what kind of approach they take, who they engage, whether they really focus on evidence. And then I think, as Corey said, that the long-term funding or stability of an office like that is a challenge as well.
I would simply say I do view it as a positive development in the sense that to the extent that I think our hopes would be that this office will convene, will bring people together, will identify places across the country where people have come together and are communicating potentially differently about this issue, that it is framed around some common value like safety and not around fractious other contentious issues. There are shared values. Right now, who would we look to do that? I think it's a lead. There perhaps is a sort of larger leadership opportunity here to bring people together and to identify and lift up those what we call them potential common sense interventions, and get and move some momentum, because I think our greatest challenge is the sense that we can't do anything about this, that it is a completely intractable, impossible problem that is paralyzing in its own right.
I guess since we're all saying something, I would say it really depends on, you know, what they're able to do and what they decide to do. I mean, as Linda pointed out, in terms of motor vehicles, things were institutionalized. And so we have the National Highway Traffic Safety Administration, whose job it is to try to make the motor vehicles and to hold the whole system safer. We have the Insurance Institute for Highway Safety, which is the insurance companies got together and said, we'll give some money to an institute which will try to help reduce motor vehicle crashes. And to have maybe for, you know, this is a nice thing, but who knows what it will do and how much money it really is going to have and how long it will last. And I mean, one of the things for me personally is if it decides that certain things are really important, this is what we want, that at least is an indication for researchers, because as I mentioned, there's so much we don't know. Maybe we should focus on the three things that they think are really important, and try to do a little more research and try to figure out how to create better data systems in those particular areas. And while I have the floor too, which is fully related, I just want to put in a big plug for the Trace. I get the Trace is free, and people should, you know, it comes. I get it 5 times a week or 7 times, whatever. It keeps coming, and I learned so much about the area which I'm supposed to be an expert on. And so I think it is just an incredible that we have this news group which is providing information about this really important topic, which was not available whenever 6, 8, 10 years ago. And so I think I just want to say this is so great that what you guys do.
Thank you. And also, I wish there was no need for it. Nothing would make me happier than the Trace not having a reason to exist, because we would have little to no gun violence. Going on to audience questions now. Somebody has a question. What is the most effective action a primary care clinician can take when counseling a patient on firearm ownership? And this is a tricky subject because doctors kind of occupy this authoritative but politically neutral space. So what is the right approach there? Maybe David, you'd like to start?
I think, like, for a pediatrician, it's that you as the pediatrician are the expert about child development, much more than parents are. And that's what you're really talking about. And just as you talk about all these other things about safety, about wearing a seatbelt and not taking drugs and whatever, one of the things you really want to emphasize is that how dangerous guns are. And you want to emphasize to the parents about that adolescents in particular can go through bad patches. And if the gun is around, if there's any attempted suicide, these people, your wonderful child will be dead rather than being able to be saved by the medical profession. That's what I would.
Would anyone else like to?
I would say just talking about it really does make a difference. There was a lot of criticism when research and screening for domestic violence started popping up, because often a woman or a patient would be asked about their experience and then it wouldn't be followed up. And that is a criticism. We need to provide the support if we're going to ask the question, but just asking the question brought attention to it. it helps support individuals by normalizing and letting them know they are not alone. But it also, even if your answer was no, you're realizing, well, my doctor's asking about that. It must be a pretty big deal. So it does change the culture just to have our healthcare community recognize this is a health issue. So that's important.
I think there's another thing too, is being familiar with terminology that people who are gun owners use, so that what we're finding with veterans, for example, is there's a difference between safe storage and secure storage. And what they consider safe storage might be to have their gun stored loaded where they can access it, but secure storage means it's stored so that nobody can access it or get it, you know. And so terminology makes a big difference overall in understanding what you're talking with the patient about, and not being judgmental. That's the other piece. It's got to be just, you know, ask the questions, provide information, provide counseling about what they can do to keep their homes safe and keep people in their homes safe.
And I would finally say that we should use the tools that we know about for behavior change and medical encounters. So motivational interviewing is a way to engage people in what the positives and negatives. People often know already, they've experienced what the positives and negatives. So we can move people along with the patients to know that it's not, if they don't walk out saying, absolutely, you've convinced me, doc, I'm going to make a change, that's not the end of the discussion. It's but facts matter. And so there was a study not long ago that indicated that many parents who have guns in the home believe that their children don't know where that firearm is or have not had contact with it. Interviews with those children found that many of them had. And so breaking some of the misconceptions or some of the misconceptions about what is and is not safe will help, I believe, get using science to do so, but translating it to the moment.
This question actually is for you, Don, from someone named Darrell Fox, who worked with you in Boston back when you developed the Young Men's Health Crew. Our current MA DPH Gun Violence Prevention Project has many elements of the crew by working with youth on life and job skills, providing options for paid training and living wage jobs as an option to put the gun down and still be able to eat. Can you talk more about models like the Young Men's Health Crew?
Hi, Darrell. It's great to hear your voice. I appreciate you raising that. It really is about people with the lived experience of not only injury, but of stigma, of racism, and really preparing them, realizing that they are the best experts to engage not only in specific issues like firearm violence, but what we call the social determinants or health-related social needs. We have historically underfunded, undervalued their work, underpaid, and sometimes expected them to work 24/7 to do work because we somehow feel that they are dedicated. But part of where we can go for the future is to ensure that they are part of the healthcare team and that we are extending that out of healthcare facilities into community. And so that much of the work that happens needs to happen in the homes of young people, where we can actually engage with the challenges that they're facing. That is a unique role that these young people can have. And I'm encouraged that there are now efforts to fund their work using Medicaid and others in a holistic, bundled, wraparound way to improve the health. Because if these young people don't feel safe, if that is not a prime objective, then we will not succeed in decreasing violence in communities. So thank you for elevating that. I appreciate all your work. It's inspired me.
Yes, one issue is the pay. We've done stories about that before, and that's definitely an issue that always needs more attention. This is a unique question. How can we design federal pressure or incentives to get states with lax gun laws to strengthen them much the way the federal government threatened to withhold highway funding from states that wouldn't raise the drinking age to 21. That was a little before my time, but some of you may remember that.
Yeah.
That's really interesting.
There were a couple of people in Congress who were champions of that legislation, and they created, it was actually a series of things. It was not just raising the minimum legal drinking age to 21, but then there were some further efforts, and a lot of this, Senator Lautenberg was one of the people who was very involved in this and very engaged in it, were things like decreasing the limit for driving while impaired to 0.08 from 0.10, implementing graduated licensure laws. So there were, a number of things, and for the some of the other impaired driving legislation too, it was a requirement for states to pass administrative per se laws, which allow immediate removal of a license if somebody tests positive or above the legal limit for driving while impaired, or they refuse to take a test. So there were a number of things that were in that legislation. So it required a majority vote of both the House and Senate in order to do that and get it to move forward. So that's really the challenge at this point in time, is getting something through both houses of Congress.
So I'd like to say something about this one too. The reason it worked for motor vehicles is that the federal government gave states a whole lot of money for road work,
Right,
and other things related to transportation. And so they had that as a sort of reverse carrot that they could withhold that funding. We don't have the same pot of funds. But there's another analogy that's interesting in that there were instances where states decided not to accept the federal highway money because they didn't want to implement certain laws. And in almost all cases, there's only a handful of these, but in almost all cases, it was because they didn't want to implement a motorcycle helmet law.
right.
It's interesting that's the one, because if you think about the power of advocacy, most people, honestly, who don't ride motorcycles don't care a whole lot about motorcycle helmet laws. And here's a state saying, I'm willing to give up this huge federal pool of money because my motorcycle advocates are saying they don't want a law for many reasons. But it is an interesting window into how a powerful advocate and advocacy body can make a huge difference that may almost seem at odds to a larger social good. So I think we don't have the same financial avenue, but we do have the same potential advocacy power, and we need to be stronger, more in front of this and more active in it, because it's the laws that are increasing things that might reduce the gun violence and laws that are doing things in a way that might increase gun violence. And so for example, looking at how many states are implementing more and more laws that don't allow local governments to make decisions, a lot of the advocates behind that are focused on gun rights. We need to look at we need policy experts, and we need advocates, who are really able to work at the high levels.
Yeah.
So this is an interesting question, and this is something we've grappled with at the Trace. Our Seattle mayor wants to install ShotSpotter in some of our neighborhoods, mostly neighborhoods of color, to react to our increasing gun violence crisis here. Is this a good idea or policy? I've heard lots of good and bad. And of course, the bad that we've been hearing lately is that it draws police to neighborhoods of color, and then it gives them a justification for over policing. But when ShotSpotter started, it was like this revelation. Now we can go to exactly where the gunshots are. How do you all feel about this technology now that it's kind of starting to sour? No one. Okay, no.
Well,
it's a tough one.
Although I will say at the very, very outset, I do not have data or know the body of research that shows the impact of ShotSpotter, looking at the really big kinds of outcomes, not just does it reduce gunshots, but how does it impact health, wellness, engagement of a community. And so on that, not knowing the data, so again, a call for good data, more research, we can't make an evidence-based decision, but we do, I think, over time and accruing more and more evaluations, looking at things like violence in workplaces and in communities, we see that there are both the sort of short-term outcomes that are directly related to the action of the implementation, but there are larger and maybe more important cultural impacts. And so the 2 points to make, not that I can answer the question directly. One, it's really important to understand the context and the cultural context of what that outcome is going to be. But the other thing that is really just as important is to understand that tools are a means to an end, and it's really the intention and the power with whom you give that tool that will dictate the kind of outcome that it has. So the challenge is this tool might work very differently in different types of communities with different types of cultural pressures and relationships. And just like AI, it's a tool for which you do things, and we want to make some parameters around those tools. Any tool is going to have to be implemented in an ethical, equitable, justice-driven way for it to have the outcome that we anticipate and want it to have.
Would anyone else like to chime in?
No, I think that's exactly right. It's
Yeah.
the same way with tasers
Yeah.
for police, which
Yeah.
could have been this 1+1 great tool, or some police seem to not use it as well as they should.
I think that, the one other thing too is just the potential that the use of that kind of tool could create some biases in various ways where, well, I don't live in a community that requires ShotSpotter, so I don't have to worry about that community. Or for children who are in a community that has ShotSpotter, do they worry about the violence? Do they, does it already imply that they're in a high-risk community? And what message does that send to them? So I think that ties into some of what Corey was mentioning on the cultural implications, but I think it's very important to look at the biases it can create as well.
And I would finally say that it is a form of surveillance, and people of color have always been under this specter of surveillance as a kind of structural state-sponsored form of violence. Sarah Brain, who was at Princeton, put forth the theory of system avoidance, which really says that people avoid systems that do surveillance. So they often generalize from police type surveillance to healthcare. And so it becomes a barrier to future. Now, if we were thinking about it in the public health sense, if we were really trying to understand surveillance to understand whether interventions were having a difference, we'd ask ourselves, would that be the thing we'd be looking for? Would we be using this tool to measure the effectiveness of our work? Perhaps in some cases that would be appropriate and others not. But I think, as everyone said, it has to have a purpose that moves us in a direction, and it has to not have the unintended consequences that are so often not measured.
Yeah.
We've gotten several questions about the role of media and Hollywood in glorifying violence. Now, we all know that other countries are exposed to the same media and video games, but do not have our levels of gun violence. But since we are a country with more guns than people, and guns are so easily accessible, and someone mentioned how Hollywood dramatically cut down depictions of smoking. Should the entertainment industry take more of a role here, considering that we are armed to the teeth in this nation?
So at my school, Jay Winston years ago was really effective at using Hollywood to try to promote the concept of the designated driver. And he was able to do that at a time when, there were just 3 major networks and there wasn't, but there were so many writers there, I think, who just wanted to figure out ways that they could do something positive rather than being told, don't do certain negative things. And so often they would just throw in small little things where, somebody at a, people would be eating or having dinner, and the waiter or waitress would be getting drinks for everybody, and one person would say, "Oh no, I don't. I just have water." And she would sort of say, "Oh, you're going to be the designated driver tonight. You're going to make sure that you don't drink." It was like no one had ever really quite heard that before, and just adding that within a year, it went from like 10% of the people had ever heard of the term designated driver to 85% at least had heard of it and really understood what the notion was. Years ago, maybe 20 years ago now, twice a group of us went, the CDC got a group of 3 or 4 gun researchers to go talk to the Hollywood, to the creative community in Hollywood. And we talked about all these wonderful things that they might be able to do and whatever. And they came up with the idea that what they should do is give themselves awards. And I thought, gee, just what we need is more Hollywood awards. But it turns out, thinking back on it, it was really good because they would give these awards to shows which really tried to figure out a way to model nonviolence or to make it so you could figure out ways to have less violent relationships. And I think, and now as I gotten older and older, giving awards turns out to be a really good thing. I mean, people love awards, people respond to awards, people are gratified by awards. And I thought that was like a tiny little thing that was good. And I remember looking at, some of the movies that they gave awards to, and I thought this is not, guns are bad or don't have, it was all about just these tiny little things. The same way I think what Hollywood did about gays has made a big difference to help allow gay marriage. That it's just became much more so acceptable. And I think that if we were clever, we could figure out ways to try to, just like everything else in public health, you're trying to figure out ways to elicit help from people who have an interest or power or knowledge or whatever. And so, yes, I think we should be doing more along those lines.
That leads into my next question and my last question from an audience member. And this is related. The COVID-19 pandemic in the US has made it very clear that an evidence base is no longer enough to galvanize transformative action. How do you see us conquering the growing gap between research and action as it relates to firearm violence? What is our responsibility as academics?
Well, I still, even as I just think science doesn't always matter, but I think science does matter. And I think what matters, like in the gun area, is one of the many reasons research is important, even research which sort of reiterates the same thing, that seatbelts save lives or that cigarettes are related to cancer and heart disease, is just the drumbeat that what most people didn't believe 25 years ago. If they keep hearing it, and here's another study which shows this, after a while it's like, oh, everybody knows that. Of course, it's just, and I think that actually really matters, and it matters a lot more than people think. And any individual study is not enough, certainly not enough for scientists, but it shouldn't be nearly enough for the average person. So I think one of the things is, yes, we have to figure out ways to talk to the public in terms that they understand, and work with advocates and work with people who are really good at changing people's minds. I mean, one of the reasons I think the National Violent Death Reporting System got off the ground was we did the pilot, but money was given by these smart foundations to groups which were advocates, groups which knew how to present data, how to present the information that this was an important thing to be done. And suddenly we had, and groups which had strong affiliations with associations which might be allies. And suddenly we had this coalition not only like we showed that this could be done in a cost-effective way, but these other groups that were also being funded by these smart foundations made it clear that in an understandable way that you could be a strong advocate for this, and people were strong and groups were strong advocates for it, and it was able to be done. And so I think, you know, if you're a foundation, a multi-pronged approach, not just funding research or not just funding, but you know, picking a topic and funding all the different aspects could matter.
One other thing too is putting a face on the data. It's not just reporting that this is what it shows, but it's also putting a face or faces on the data. And the more you can help people to relate to the people who the data are applied to, the more they may care about doing something in order to prevent what happens. So it's really important when you hear that doesn't happen in my neighborhood, or I don't know anybody who's been impacted by gun violence. You really have to be able to put a face on the data and let people know that this is impacting everybody.
Well, thank you very much for a great discussion. And thanks to the audience for some really great questions. I'd like to pass it back to Dean Galea.
Well, first of all, thank you, Jennifer, Linda, David, Corey, and John. I've been immersed in this topic for more than a decade, and I learned tremendously from each of you every time I listen to you talk. And I also learned from our audience. That I think has been a really excellent, engaged conversation in the chat and some really terrific questions. You know, we're at a paradoxical time in this history of sort of academic engagement with gun violence. We are, as I was discussing with some of the speakers before we started, there's much more attention, many more resources, more junior scholars engaged in this topic than ever before. At the same time, we're at a peak number of gun violence deaths and injuries in this country. So I do think that we are at an inflection point, and it is continuing the conversation, continuing the work that everybody here is doing, both in the panel as well as in the audience, that will turn, bend the curve to where it should go. I appreciated Jennifer's comment about nothing would be better than not to have reason to actually have these kind of conversations. And I lean into hope and optimism in saying that with the work of the people involved in this call, we can actually get there at some point. So thank you, everybody. Thank you for all the work you're doing. I want to thank Dr. Magana and the ASPPH for their leadership on this and for co-sponsoring this. Everybody have a good afternoon.